because salt sensitivity is a very unique topic. I'm not showing some original data from India. We have some unpublished work which will come out and get data unlocking next month. And Brand did allude to that, and so did Narsingan, that hypertension is a leading factor for death and disability. And I'm not looking at obesity, alcohol, which will flow after this meeting, sedentary chairs, which are all of y'all are sitting in, because sitting is the next smoking, unhealthy diet. I'm only focusing on sodium intake and salt. And salt sensitivity is a challenge to understand. Significant blood pressure response to dietary salt changes is salt sensitivity, very simplistically. Healthy individuals, probably 1/3 of them have salt sensitivity. In hypertensives, in Indian population, in the diabetic world, people living with diabetes, it's around probably 70%, again 80%, but that data is unpublished. And in the non-hypertensive world, probably 60%. That's where it stands. Some people feel 55, some people feel. But it's more common in older adults, in African Americans. The data is clear cut there. On the evidence base is a little higher quality there. CKD, and then of course diabetes, metabolic syndrome, people living with that. So that's where we get in the picture. And obviously, Dr. Narsingan did allude to that excessive sodium does impact health. And dietary sodium intake elevates blood pressure and increases cardiovascular risks. And this effect is amplified or exaggerated in salt-sensitive individuals. And clearly now we recognize worldwide that salt sensitivity is an independent risk factor for cardiovascular disease and mortality both. Unfortunately, the pathophysiology of salt sensitivity is very complex, and I want to give that complex topic a little more simplification because it has renal functions, and therefore we have two very top nephrologists, one global and one very much local. Professor Allen is here. Then vascular functions, we have cardiologists with us, immune system, and gut microbiota. And unfortunately, what happens in salt-sensitive individuals is some responses are impaired. There's reduced peripheral vascular resistance, and there's decreased nitric oxide production, and the net result, net is increased blood pressure, with high salt intake. But there was this O'Keefe data which was published just last year, and I put a little cartoon there that you need a little salt to motivate workers. The salt had a mine. Salzburg, the name of the city, is named after salt. Salt had walls. The word salary comes from salt. So salt used to be a big thing in the past, and there were the sugar and salts are there. And this is a data of sodium restriction and insulin resistance based on a background that low salt diets are recommended for lowering blood pressure. And that may not be true. Unintended consequences of worsening insulin resistance are associated with low salt intake. That's a big pathophysiological thing. So that might provoke all of you. So when there is a lack of sodium, it increases insulin levels as a compensatory mechanism to help the kidneys to retain sodium. And also when you actually cut out salt, it elevates stress hormones, causes vascular stiffening, vascular and systemic insulin resistance. So actually when you're restricting or cutting salt, you are actually accelerating insulin resistance, and salt restriction also has data, published data to show that it can increase mortality and cardiovascular events. And this is very, very controversial. So what's the evidence base? So this was a public, and this is a public study where they looked at 23 studies. It's published of human clinical studies looking at low salt diets on markers of insulin resistance. They looked at a PubMed engine. They looked at the negative harms on insulin or glucose. And they looked at various designed small studies, crossover double-blind design, double-blind randomized controlled trials, on salt-sensitive, salt-resistant hypertensives for 1 week with salt restriction and normal salt intake. Again, a randomized double-blind placebo-controlled crossover data. And again, they looked at insulin sensitivity was significantly reduced in people with sodium deplete diet. And higher salt significantly increased insulin-mediated glucose disposal by 21%. And low salt intake significantly increased the renin, aldosterone, noradrenaline compared to high salt diet. So very provocative. So clearly there is data now, public data, both in the animal world and in the human world, that low salt activates sympathetic nervous system, activates renin-angiotensin system, increases of NEFA and volume depletion, and lower intracellular sodium concentrations, which increase glucose absorption in the intestine. So obviously, when there is salt restricted or salt free diet or low salt, it will worsen insulin resistance. It will worsen blood lipids and blood viscosity and creatinine and uric acid and kidney function. It will activate a whole sympathoadrenal axis, elevating heart rate, outweighing the blood pressure lowering benefit. So obviously, this is very controversial. Salt restrictions should be used with caution. And this is a debatable issue, and I've deliberately started this controversy because this is a controversial topic. So I thought, and these are not slides given to me by my friend Anil. These are my slides, and I decided to put this out here, that eating diet with whole foods and whole grains we don't eat whole grains, we'll eat all inflammatory diet today, and maintaining normal sodium intake per day is a better option for overall metabolic health and blood pressure. Having said that, unfortunately, we live in a world where, if you have seen this graph, cardiovascular mortality is directly linked to sodium consumption. From a public health standpoint, and Paul is a public health expert as much as he's a nephrologist, the amount of sodium we are consuming in population is very high. We love our papads, our pickles, our preserved foods, our processed foods. Everything what we put in a refrigerator, and whatever you put in the refrigerator, wherever you use salt as a preservative, whatever preservative we use, it's all having excess amount of salt beyond reasonable doubt. So clearly, if you look at South Asian scenario, excess salt is the 7th leading cause of death in our region. Worldwide, it is number 11, but in India, it is number 7. So it's actually killing people. Too much of salt is killing people. So though I said that you need the right amount of salt, don't be salt-free completely. You need some adequate sodium to regulate stuff. From an insulin resistance standpoint, you have drugs to manage that. But salt kills, clearly data there. And this is again Indian data by Kumbla and Japi, suggesting across India we love salt. We are a salted country. We live in humid climatic conditions. We need to do more data production. But what is unique in our population is that the average salt intake is 5 to 6-fold more than the physiological intake. So we are having too much of excess, and which is why the restriction is recommended, which is why going low on salt is recommended, because we eat too much and we have excess 5 to 6-fold of salt. And it's all coming from these pre-prepared processed foods, and with the Swiggies and Zomatos of the world, it's actually becoming worse. And clearly we know that any restaurant of processed food, and we are in a very nice hotel here, clearly we will see that lot of food is preserved, whether it's naturally occurring, added on a table, whatever it is, across geographies. Processed foods and ultra-processed foods are the prime cause of Professor Salim Yusuf's study, Intersalt, clearly recognized that if you just have 6 grams of sodium over 30 years, the systolic blood pressure goes up. So clearly the data on systolic blood pressure and salt is clear-cut. This is 52 communities worldwide, 10,000 plus population, direct relationship between blood pressure and age, and clearly we recognize that. But not everybody is salt sensitive. There is a clear variability. Just like, today morning I was talking on clusters in diabetes. We have clusters in diabetes. As hypertensionologist, which Dr. Narsingan, I like the way he talks, we need also to have clusters in hypertension. And we are actually going to publish some data. And I would share that data with Narsingan. We can see whether he could collaborate with us to publish that. We have blood pressure clusters on salt. Some are salt sensitive, some are salt resistant in our population too. And there is a relationship between them and insulin resistance, because in the diabetic world, it is very different. And therefore, when it comes to salt sensitivity, and I would like to give more some water, clearly we see that there are different theories. We know in the skin, there is a theory that osmotically inactive storage of sodium occurs there. We know the ENaC, the endothelial glycocalyx, and the ENaC mediated vascular dysfunction theory. We all know the vasodysfunction theory of nitric oxide, the oxidative stress, the neurogenic dysfunction, the angiotensin II, the TGF-beta, and the endothelial dysfunction theory. These are all theories which basically cause too much of insulin resistance and systemic vascular resistance. So if you look at this paper, it's a very nice paper in Kidney International, published in October 23. novel mechanisms of salt-sensitive hypertension, clearly we recognize a couple of simple points. That too much of sodium is a very important lifestyle factor for blood pressure increase and hypertension. Despite of numerous studies in past decades, the pathophysiology explaining why some people are salt sensitive and have an exaggerated amplified response while others are not is not well understood. What is coming out are three things: that there is a lot of epigenetics in it, there's a lot of gut-kidney axis involved, including gut microbiome, and there is a immune mechanism of mononuclear phagocytic system. And we also have three drug classes in having impact on salt-sensitive hypertension, apart from the classical chlorthalidone, which I'll talk a little later. In the diabetic space, the SGLT2 inhibitors, the mineralocorticoid non-steroidal antagonists, and the aldosterone synthetase inhibitor. So those are the three classes of drugs which are impacting them. And therefore, the kidney-centered mechanisms, the vasoconstrictor mechanisms, are relevant in understanding and treatment of this blood pressure phenotype. So we need to phenotype blood pressure. Just like we phenotype diabetes, we need to phenotype blood pressure. And I'm sure when the last word is by my good friend and guru of hypertension, Professor Ram, I'm sure he will talk about phenotypes. I'm very confident of that. So there are old concepts of salt sensitivity and new concepts of salt sensitivity. It's all about shift to the right. And there are two theories of salt sensitivity. One is, of course, the kidney center theory, which means the high blood pressure allows pressure natriuresis to match the sodium excretion with the intake. And clearly, when the intake is not equal to excretion due to low number of nephrons, and that's linked to age, that's linked to female gender, that's linked to low birth weight, which we have in our population. Dr. Yagnik works on it, small gestational age, which is very common from the Vellore group and the Delhi groups cohorts, hypertension, CKD, low potassium diets, of course, African ancestry. We might even add a South Asian ancestry here now, but we need to generate that data, and some of us are keenly involved in that, low renin status. And then there are genomic variants of the ENaC status. So that's the kidney-centered theory. And then, of course, the vasoconstriction theory, which means high blood pressure is a consequence of the incapacity to vasodilate after a sodium load. And that leads to vascular resistance, endothelial dysfunction, a perturbation or disturbance in the endothelial glycocalyx, and that extra vessel sodium milieu leads to a sympathovagal imbalance and disturbance. And that's really now how the whole salt-sensitive hypertension mechanistically has been explained. And then, of course, gut microbiome is everywhere. They say that it's not how rich you are, what's your bank balance, but it is how rich you are is how good your gut microbiota are. And clearly we know that upregulation of the Th17 actually triggers a cytokine called IL-17, and that clearly has a direct impact. So fundamentally, the classical natriuretic pressure, natriuretic graphs which you saw in salt-sensitive world, salt-resistant world, are all the shift to the right. So when you classically talk to public health people or people who do experiments in salt sensitivity, they will all tell you that it is the salt-resistant, the salt-sensitive, and the normal population. And what happens in salt-sensitive population? It is significant change of blood pressure in relation to the sodium in the diet with hypertension, and the slope of the pressure natriuretic relationship is less steep and shifts to the right. And that's why the blood pressure changes in sodium intake is greater, but that is the exaggerated response. So salt-sensitive people who are the hypertensive phenotypes, they have a pressure natriuretic relationship which is altered, and most people who are living with diabetes or insulin resistance actually have that. And therefore, they have a net urinary output. So clearly, beyond that, we have the volume loading and the vasodysfunction theories of salt-sensitive hypertension. I would not allude to go too much into that, but these are the two major theories. We recognize them, and we know ultimately the net yield is increased systemic vascular resistance. So obviously, when you look at all the paradigms, fundamentally what's happening? The chronic high salt ingestion produces endothelial dysfunction, even in the salt-resistant subjects. So that it's not to say that only salt sensitivity is important. Even in the salt-resistant subjects, you will get that. And this complex syndrome of salt sensitivity is a function of the endothelium. And it's clearly involved integrally with vascular responses of salt intake. There's a lot of metabolomics on it. In fact, there was this whole study published in the last year on the molecular characterization of blood pressure response to sodium in salt-sensitive subjects. And this is a gene salt replication study. It's a Chinese study where they did a simple experiment of 7 days of low sodium feeding, 7 days of high sodium feeding. They used latent mixture models. They looked at various blood pressure trajectory of responses to sodium interventions. And then they looked at most highly sensitive, salt-sensitive population and the most salt-resistant population. And then they did metabolic profiling. And then they mixed and matched, and they actually came out with their own hypothesis. And they further went, and this is the association of salt sensitivity of blood pressure and hypertension in the Chinese Tibetan population. And they clearly suggested that in the Chinese Tibetan population, the salt sensitivity is associated with increased risk of hypertension in the Tibetan population, indicating the need for clinicians to look at salt sensitivity blood pressure and decrease the risk of hypertension. But as endocrinologists or diabetologists or metabolic physicians, I would ask you to look at this work published in the endocrine research, the JCNNM, which is old data, but clearly suggesting that in the context of individuals with type 2 diabetes, the blood pressure sensitive to salt intake and frequency of low renin state are both increased compared to non-diabetic population. So this was assumption, but we can't assume in medicine. We need to validate it. And therefore, in this study, you can look at the type 2 diabetic population and look at the entire intermediate phenotypes of altered RAS, low renin, and non-modulation associated with salt-sensitive blood pressure occurred in different frequencies. And actually, there was clusters. And clearly, you can see that the non-modulation as a mechanism of salt sensitivity was clearly illustrated in people living with hypertension and diabetes. I wouldn't dilate into that, but maybe over dinner we can discuss that. So clearly, we need to have a mechanism-based strategy to that, and salt sensitivity has these differential responses. The classical loop, you eat too much salt, there's pressure natriuresis, and it's a vicious cycle and cascade. And of course, we have the servo control of renal perfusion and the shift to the right, the shift to the left, and we have both in chronic renal function curve as well as in the acute pressure natriuresis response, the behavior of salt-resistant and salt-sensitive population is different. Clearly, we recognize one thing, that in the thick ascending loop of Henle, which resorbs salt and not water, there is a sodium-potassium ATPase. And that's a major cause that the overactivation of the co-transporter here is a major cause of salt sensitivity. And adrenal gland and the central renal sympathetic nervous system also is directly involved in sodium resorption. And finally, the gut microbiome. We clearly recognize that sodium modulates the composition of gut microbiota. Because what happens is when we eat too much of sodium or salt, it decreases the lactobacillus species via production of metabolites and various other mechanisms. And then that high sodium activates dendritic cells. They basically pump out more Th17 cells systemically. They make pro-inflammatory molecules like IL-17, interferon, and IL-6, and they cause renal inflammation and systemic inflammation and increased blood pressure. This is the whole hypothesis of sodium, gut microbiome, and basically we are fibropenic, just like we are sarcopenic Indians, we are fibropenic Indians. We have depleted fiber, and we are eating too much of sodium, and we are using sodium as preservatives. Fundamentally, there is a down regulation of lactobacillus. And the microbiome shift which occurs is very deleterious to health. And that triggers immune responses, inflammation and blood pressure, and we need to switch that. And then we have molecules which are targeting salt-sensitive hypertension, and in the diabetes world, we have SGLT2 inhibitors which have arrived, and there might be a role here in some ways. I don't want to dwell into details of genomics here, but there is candidate genes, their variants, their mode of action, and proteins on that. But clearly, in salt-sensitive hypertension, both for renal sodium transport and for vascular reactivity, there are multiple genes which are involved, which make an individual familially more predisposed to salt-sensitive hypertension. And even on epigenomics, both in the fetus as well as in the elderly, and this data is very clearly there are different epigenomic mechanisms which fundamentally either modulate the renal sympathetic system or the renal blood flow, which impair the renal sodium handling for sodium hypertension. And also we have, I showed you that immune system is, and the influzomome is impacted both by gut microbiota and salt-sensitive hypertension. So clearly we have that. We also have data to suggest that the decrease of endogenous bradykinin levels clearly lead to vasodilation natriuresis. The ANP in salt-sensitive patients blunt the natriuretic effect, the diuretic effect, increase hypertension and blood pressure. And then the sympathetic nervous system activity leads to more vessel contraction, calcium accumulation, sodium transport. And this whole enhanced sympathetic system causes salt sensitivity. So what happens? Why is there amplification in salt-sensitive hypertension? Why am I talking about it? Because excess salt causes central sympathoexcitation and overproduction of brain reactive species, and sympathoactivation leads to increased sodium resorption and blood pressure via different pathways, and I wouldn't go into pathways of that, but clearly salt excess leads to a central sympathoexcitation, reno-specific sympathoexcitation, and increase in proximal sodium resorption and increase in the distal sodium resorption through different mechanisms. Ultimately, net result is sodium retention in salt-sensitive hypertension, and clearly high salt intake triggers the RAC1 activation of kidney in salt-sensitive hypertension, and clearly we know these pathways which are involved in that. But does it matter long term? I'm talking of all these pathophysiological salt sensitivity, and we have studies from Japan, we have studies from US, which have shown that it impacts lives. The Japanese study on the left shows that salt-sensitive people have more cardiovascular events than people who are non-salt sensitive. So this is outcomes data, pooled outcomes data suggesting that salt-sensitive people, at least from the Japanese data, and we need to publish Indian data, clearly are having more cardiovascular events. And if you plot the survival curves from the United States, if you look at N as normotensive, R as salt resistant, S as salt sensitive, and H as hypertensive, salt resistant people had a greater survival than those with hypertension and then those with normotension and salt sensitivity. So clearly there is some data on survival, on mortality, both from Japan and from United States impacting outcomes. And if you look at mechanistically loading people with salt, here you can see both on arterial, mean arterial pressure, systemic vascular resistance, cardiac output, and cumulative sodium balance. And if you look at salt sensitive versus salt resistant, clearly you can see salt sensitive individuals do not effectively reduce systemic vascular resistance in response to increasing salt intake. And this is what is exaggerated. So really sodium reduction lowers blood pressure, and that's clear cut. And in our South Asian population, in CKD, there's a RCT. There is a RCT which is published. So we have data on that. And also we have good data on clusters of the DASH cohort of blood pressure responses to salt intake. And we have various mechanisms of various macronutrients and micronutrients on salt sensitivity, both in animal world and human world. And I don't want to go into details of that. So where does that lead us to? Well, the AHA-ACC and some of those guidance are written by Paul and many of the others, that salt sensitivity is a marker for increased cardiovascular risk. Clear recognition there. We have detection challenges because current recognition techniques are impractical for routine practice. We can't do salt sensitivity in routine practice. We can't, don't go on the internet and WhatsApp University and see what's my sodium IQ. It's not going to work. These are complex areas of research. But from a management standpoint, we need a dietary sodium restriction with individual responses. But in the hypertension management, and not because IPCA is sponsoring this talk, we need to not forget the role of diuretics. And that's something which we need to recognize. And that's why the last 5 minutes, Brian, I'm going to take on the need to treat salt-sensitive hypertension. Because there are no standardized therapeutic approaches to clusters of hypertension, like salt-sensitive, how you treat, salt-resistant, how you treat. But we need to have a consensus, yes, salt reduction is important, and then you have conventional antihypertensive therapies. And WHO classifies sodium restriction as a cost-effective method. Dr. Narsingh just highlighted that very clearly. There's a network meta-analysis available on efficacy of antihypertension agents in salt-sensitive hypertensive subjects. And when we combine a CCB with diuretics, they are probably the most effective drugs in this cohort. So if you have a salt-sensitive cohort, there is some data with some evidence to suggest that if you do a CCB with diuretics, it is reasonable to treat. And it's important to recognize, and I'm not going into nephrology world because we have two brilliant nephrologists in the audience, one from New Orleans and one very much from Mumbai. Clearly, we recognize that diuretics have a role in salt-sensitive low renin hypertension. And clearly we know, and we have data to suggest, that chlorthalidone otherwise also clearly has data to show. Initially, the data came in the salt-sensitive hypertension from the African patients, older population, people who had comorbidities, more severe blood pressure. But most people put metabolic syndrome and diabetes on the side. But from an endocrine standpoint, I'm a little more selfish that diabetics, we are the diabetes capital of the world. I was a part of the ICMR India cohort, which Dr. Mohan is the first author of. And we have 101 million people living with diabetes in India. Out of the 500 million people living in the world, 100 are living here. 1 out of 5 people are living with diabetes. And therefore, it's important to recognize this. And therefore, it's not surprising that diuretics have an effective role in this population. So that's the reason I'm talking of it. And then you need to differentiate thiazide-like diuretics over diuretics. And I don't want to dwell into Dr. Ram's territory because that's his domain. He loves that domain of his. But clearly, the 2017 ACC-AHA, which I'm sure Paul was a part of and Dr. Ram was a part of, preferred diuretic treatment. Chlorthalidone was singled out because it had proven cardiovascular risk reduction and recommended that to substituting the standard hydrochlorothiazide. And clearly they said either you use a chlorthalidone or a indapamide. And hypertensives living with diabetes, ADA also said, give a preference to thiazide-like diuretics. Because they are longer acting, they have proven cardiovascular event reduction, they have different mechanism of action, they are pleiotropic, they are okay on metabolic profile and subclinical markers, and so on and so forth. In the CKD world, I think the data is clear cut. Okay, we need, there is a case for chlorthalidone, but of course, all diuretics, and CLIC trial very clearly showed, they will have low sodium, low potassium, low magnesium, high calcium, alkalosis, AKI. We need to be vigilant. So all it says is be vigilant, but clearly diuretics are right there. And don't forget them. In fact, all-out trial was the first to show that was the only thing which mattered. And therefore, if you look at hypertension management, adult CKD guidelines, the recommendations are pretty clear-cut. And if you look at the ESC guidelines, which Brian did allude to, 2023, ACE, ARB, CCB diuretic. You need to recognize them. You just can't ignore diuretics there. So I think it's important that not to dismiss out diuretic from that window. If you look at the true resistant hypertension, again, not controlled on ACE, ARB, CCB diuretics are very, very much there. And clearly from CKD stage 1 to 3, with the EGFR more than 30, beyond a MRA or a beta blocker, alpha blocker, central agents, that's the pathway. CKD stage 4 or 5, not on dialysis, below 30, chlorthalidone is preferred. And then, of course, others come in, so those pathways are clear-cut. ADA 24 is just out, full text available just last week. And clearly you can see that if you have severe hypertension more than 160 or 100, start with 2 agents. If there is albuminuria and CAD, ACE ARB is not going to be sufficient. You might need still a CCB with a diuretic. And most of our patients land up with triple agents. And therefore, I'm telling you that there's a call for action among clinicians who take care of people living with diabetes, with hypertension, that do not just start a patients on an ACE ARB or a CCB, but look at chlorthalidone like molecules or diuretics. So clearly they are there. You need ACRB, but you need to also recognize thiazide-like diuretics, which are longer acting because they reduce cardiovascular events like chlorthalidone and indapamide. And clearly, we need to not forget CCBs as well. Our own RSSDI guidelines also have put a place out there. They are now been publicized. Some of us are in the fine print of those papers. Clearly, thiazide-like diuretics like chlorthalidone have superior blood pressure reduction in patients with resistant hypertension. WHO has been very mindful. They have said there are 3 pathways of antihypertensive drugs as first line. And right at the top of their pecking order, it's thiazide and thiazide-like agents. Then it's ACE and ARBs, and then it's long-acting CCBs. Strong recommendation, high certainty of evidence. So they stuck to their guns. They're very much there. They're very much global. And they're very clear about how they talk. And usually start, if there is comorbidities with CVD, hypertension, CKD, diabetes, start with 2-drug combination in a single pill for compliance, convenience, adherence. And clearly, thiazide-like diuretics have a place right there. Younger and older, I don't want to go into details. Again, as I said, Dr. Ram will be there. Dr. Siddharth is no more with us, but in the Indian hypertension guidelines, which were published in 2020, you can see in the C and the D, don't forget the calcium channel blocker and the diuretic. Don't just be on ACR or a beta blocker. That's what we need to do. And if you look at JNC8, of course, JNC is dead. Okay, in general, in the non-African population with diabetes, the initial hypertensive treatment should have a thiazide-like diuretic. It's very much stated there. And of course, in the African population with diabetes, again, they have put the word of thiazide-like diuretics there. So I think we should not forget that. Having said that, Pran, I'm done. I hope that I didn't shoot too much of my time. We are all living in a digital world. So beyond salt sensitivity, and I'm sure that you will get a lot of preserved and salted food and inflammatory food today, which you may skip if you want, okay? But do 1 hour of digital detox every day. And don't just treat health, but also if you're treating health with health, treat happiness. Because it's important that if we are treating people living with hypertension, they should not be in distress. They should be happy and healthy both. Thank you so much for a patient hearing.